Hello, my name's Jason Bedford. I'm a specialist in endodontics. So tip number one, getting the diagnosis right. Obviously nice for your patients if you get the diagnosis right first time. There's no substitute for a full clinical examination, taking into account the patient's medical history, their dental history, the signs and symptoms that they're presenting with. But still in these days of CBCTs and 3D imaging, we use our standard periapical films as a great way of establishing a diagnosis for patients. Obviously, we know that there are certain areas of the mouth where a periapical can be quite difficult to interpret. Lower incisors, for instance, there's no one root canal, or there are two root canals in that lower incisor. Upper sixes and upper sevens are the absolute classic, where it can be very difficult to establish a diagnosis just from an X-ray. This patient is the perfect example. She has a root canal that was performed 6 months ago. General practitioner was perfectly happy with it, but she's persisted in having pain, particularly when she taps the tooth. Thoughts going through the general practitioner's mind when he referred it was, can't be my root canal. Root canal looks great on the X-ray. Is it an occlusal problem? Is there a fracture there? Is the fact that we've not crowned it 6 months on, does that mean that there's apical leakage, coronal leakage going on? All of those things were running through his mind. This is the first X-ray that we took and when we first saw the patient, and that confirms that there's a great looking root canal, very little in the way of apical pathology. There aren't many clues on this X-ray as to what is going on. Now, rather than resort to a CBCT or opening the tooth up and exploring for root fractures or adjusting the occlusion, my first step, whenever I've got a patient where there's a conflict between the periapical view and the patient's symptoms, is simply to take another X-ray. So this is the X-ray that we took literally 30 seconds later, and you can see by angling it slightly mesially and slightly down, we project that apical portion of the tooth against the sinus there, and now all of a sudden you can see that there's very clear apical pathology associated with that tooth. And so the answer for this patient is not occlusal equilibration or taking that tooth out of occlusion or providing her with a splint. The answer is to simply retreat this tooth. So top tip number one, if your first periapical isn't giving you the information that you require, taking a second one from a slightly different angle, normally angled mesially is more straightforward, and slightly lower will give you a different projection on that tooth and reveal far more information. Periapicals are 10% of the dose of an OPG and only 1% of the dose of a CBCT. So taking an extra periapical is perfectly justifiable if it helps make a clearer diagnosis for the patient. Okay, tip number two, isolation. Now, we all know that rubber dam is mandatory for root canals. It speeds up the treatment, gives you better access, it's more comfortable for the patient, and of course it protects the airway and keeps the area nice and clean and dry. But it's difficult to place, right? Well, here's a video that shows how rubber dam can be placed quickly and easily. The key to rubber dam is keeping it really simple. Get the right rubber dam. The rubber dam I generally use, and a lot of your colleagues will be using, is the award-winning Isopharm. It's latex-free, it's incredibly stretchy, it's a nice relaxing blue colour which is comfortable for your eyes, particularly when you're shade taking. You can see how stretchy the material is. The other thing to keep it really simple is where you punch the hole. There's no real need to use templates or guides if you punch the hole in the same place each time. The way I always do it is find a point in the centre of the rubber dam, move diagonally towards one corner, about an inch or 2.5 centimetres, and punch your hole in that point. Don't punch one hole, punch 3 overlapping holes, just using a medium-sized hole on the punch. That gives you a hole that's big enough to stretch over a clamp, but not so big that there's any risk of the dam tearing. And by doing that, and by simply rotating that dam and flipping it, you could have top right, bottom left, top left, all by punching that hole in the same place. Keeps it nice and simple, nice and consistent for your nurses. The other thing is to get the right clamps. There are two types of clamps that I like to use. You can see here the Fiesta color-coded clamps. They're a great little set. They've got pretty much everything you're ever going to need in terms of a rubber dam clamp, And you'll also notice that they're matte, they're not shiny. If you start to use a microscope or you're using loupes with illumination, you'll find that shiny rubber dam clamps reflect back, and that can be quite disturbing, little flashes of light as you're trying to work. Even better are the satin or black finish rubber dam clamps that are now available. So the key to rubber dam is keep it simple, punch the hole in the right place, and get the right clamps, and practice. And it will make your life a lot simpler. Whenever we do a training course, we always ask dentists what the biggest issue they have with their root canal treatments is, and inevitably it's finding root canals. So tip number 3 is how to find root canals. If you're not using magnification, then you're missing a trick. Loupes are perfect for general dentistry, a size 2.5 to 3.5 times. Will massively enhance your ability to diagnose caries, to see fractures, to refine margins on crown preps, but they're also wonderful for finding root canals. So if you're doing a lot of general dentistry, 2.5 times, 3.5 times loupes will be perfect. If you're tending to do more endodontics in your daily work, then you might want to look at 4 or 4.5 times magnification. At that point, you probably are considering a microscope. Not everybody has £25,000 for a microscope. If they're not doing enough endodontics, then perhaps loupes would be a better idea. Don't fall into the trap of thinking, I'm only 26, why do I need loupes? Trust me, they will lengthen your career, they will enhance your career, and the earlier you start, the better. Equally, if you're in your 40s and you think you've got away with them so far, you're kidding yourself. Loupes will make a massive difference to your ability to find root canals, but also the general quality of your work. Once you do start using loupes and magnification, though, you'll start to find that a lot of the endodontic instruments, a lot of the probes that we use are simply too big, and you start to hunt for smaller and smaller instruments. One of the challenges with hand files is that the tips are quite a long way from the handle of the instrument. And quite often you'll find that your big fat fingers get in the way and you can't actually see where the tip of the instrument is. Something I've been using for some time now are contra-angled hand files mounted in an endo handle. You can see here on this video that it's very simple to take one of these endo handles, take your whatever file you prefer, mount it into the endo handle, and then using something like a mixing pad, just gently bend that file to give you that contra angle that we have with our instruments and we have with our handpieces. And now all of a sudden, as you can see from the video, you can start to, rather than seeing just the top of the file or your fingers in the way, the increased access you get means that you can now start to see the root canals, you can start to see the root canal orifices, and you can identify them much more simply. It's also really nice for opening up that coronal part of the canal. And you can just see on this video where we just disturb a little pulp stone. That little pulp stone is just dying to dive down one of the root canals, and you wouldn't have seen it had you've been using that little endo handle rather than your file. And you're just able to pick that little piece of pulp stone out and prevent it from blocking up your root canals. So tip number 3, get some loupes. They'll massively enhance your general dentistry, but also your endodontics. And also, give these endo handles a whirl. You'll find that your access and your ability to visualize root canals leaps massively. Tip number 4 is around using your apex locator. Whenever I ask dentists on a training course whether they have an apex locator, 90% of them will pop their hand up and say yes. If I then ask them if their apex locator works, 90% of those people who put their hand up will drop their hands and say no, they really struggle with their apex locators. There are 2 tips with apex locators. Number 1, don't listen to the reps. The reps will tell you that these things will find the apical constriction, they will tell you the length of the tooth down to an accuracy of 0.5 millimeters, they will cook your tea and take your kids to school. These things will do none of those things. The second thing to recognize with your apex locator is ignore the numbers. Every apex locator on the market, as you can see from the image here, has numbers in a scale on the side. Those are not millimeters. They're only there to give you a rough guide of the progression as you pass down the root canal. Don't make the mistake of thinking that they are, when you're at 0.5, you're 0.5 millimeters from the apex. That's not how apex locators work. Your apex locator is most accurate when the file has just exited the apical foramen. And at that point, depending on your apex locator, you will see something along the lines of apex or over or a little red flash. So when you are using your apex locator, generally a size 8 or 10 file is the best approach, and work that gently down the root canal. And as you can see from the video, you'll see the apex locator start to track as you get closer and closer to the apex. The point you're looking for is to get to where it says 0 or apex, depending on your apex locator. Once you get to that 0 point, just make a gentle quarter turn clockwise to see the file just edge out through the apex, and you'll see over or apex flashing. At that point, your apex locator knows exactly where it is. Having gone just through the apex, you can then turn that file anti-clockwise and withdraw it, and it will just pass back up into the root canal. And at this point, your apex locator will start to track with the file. So as you move the file up and down the canal, it will start to track as it's got more accurate. The point you're looking for is to go through the apex and then back to the point where your apex locator is at that 0 point or apex, and use that as your measurement guide. Set your reference point using the stopper and then measure your file. And it's at this point where you realize that all the marketing around your apex locator is irrelevant, because now all apex locators are incredibly accurate, but now we're reliant on ourselves and our nurses to measure that length that we've just established. And as you can see from the images here, most of the endo rings are not accurate enough to match your apex locator. So what you'll find is that on that top endo ring there, the millimeter markers are almost 1/4 of a millimeter wide. So it's impossible to measure the files from a practical point of view as accurately as your apex locator can. So what we do is we establish that 0 point by going beyond the apex and then back to that 0 point. Measure that file, and the most practical way of establishing your working length is simply to round that length down to the nearest millimeter. That means that your preparation will be within the root canal, short of that apical terminus, and consistent. A good tip though is to keep the file that you went just ever so slightly long. Keep that file separately and use that to repeatedly go back to that point throughout the procedure. That means that you've established patency, and using that file you will maintain that patency right the way through the procedure. That will mean that you're much more likely to avoid losing length as you go up through your files, and maintaining patency is one of the prognostic factors in success in endodontics. On the other hand, if you want to be incredibly accurate with your measurements, rather than using an endo ring, you can pick up one of these. They're incredibly accurate, and they've got nice big numbers on as well. So if you want to be more accurate, then rather using an endo ring, these electronic calipers are great and very, very cheap. So top tip for apex locators: remember that they don't find the constriction. They're most accurate when they just disappear out through the apex. And also, that number guide isn't millimeters, it's just a guide. Pass that file down through the apex, withdraw it slightly to that 0 point, and use that as your measurement and your reference guide. Another top tip is to, when you are partway through the procedure, once you've opened up the coronal part of the canal, it's worth just checking that your working length has stayed the same. Quite often when you open up the coronal part of a canal, you will effectively shorten that canal, and you may well find that the working length you established at the beginning is just a little long now. Tip number 5 is shaping root canals. Now, there are dozens of different ways of shaping root canals out there, whether you're using a rotary file or a reciprocating file. Regardless of which system you're using, we generally recommend creating a guide path with hand files before you move on to your rotary or reciprocating system. A guide path is simply taking an 8 or a 10 file down to length, and then a 15 or a 20 to your working length. And that creates a nice path down which your rotaries or your reciprocation files can run and more freely without engaging dentin too heavily and risking fracture. Traditionally, as I say, it's been done by hand, maybe using lubricants or lubricating gel as well. But it can be quite laborious and it can be quite tricky. And if you try and do this in an S-shaped plastic block, for instance, you'll see that it's very easy. As the instruments go from 8 to 10 to 15 to 20, they become much more rigid and you start to transport the canal. Changes in metallurgy and engineering and file design mean that now most of the rotary manufacturers have what's called a guide path file, a rotary guide path file or a reciprocating guide path file. These replace your 15 and 20 hand files in creating that beautiful smooth path down to length. So these days, generally my sequence is an 8 or a 10. Then my guide path file, and the one I use is a 1503. That replaces my 15 and 20 file and means that I can dive into my rotaries much more quickly. And you'll find that these guide path files, they stay centered, they create a nice smooth path to length. Typically they're an 02 or an 06 taper, somewhere between a 10 and a 19 tip, but they have very narrow flute diameters. So they're really fine, really smooth looking files. And if you follow the manufacturer's instructions in terms of speed and torque, they're really low risk of fracture, particularly if you keep them loose in the canal and use a nice gentle touch. But they will rapidly get that nice smooth centered guide path and your rotaries will follow much more simply down to length. If your system doesn't happen to have a guide path file in there, they're interchangeable. Find a manufacturer that has one that slots in between your 8 and 10 file and your rotaries, and you'll find that they have a really slick addition to your preparation. Now, obviously, if we're going to speed up preparation, that's great, but I wouldn't be tempted to shorten my treatment time. What I'd be tempted to do is take the benefits of the guide path file, take the benefits of the enhanced speed and efficiency of your shaping, but use that additional time for more irrigation. Irrigation is what leads to clean root canals, not efficient shaping. And we'll come on to irrigation in a second. Tip 6 is around irrigation. You simply can't irrigate enough. People often ask me, how much irrigant should we use? How long should we be irrigating for? And here you can see is how we like to use our irrigant. Lots of it, and it's all about turnover. Research confirms that rather than setting an arbitrary time limit on your irrigation, it's important that if, for instance, you have 30 minutes for your irrigation, for your appointment rather, starting from the very beginning, as soon as you get into that pulp chamber, start your irrigation going and irrigate right the way through the procedure, particularly after every file that you use, right from start to the point where you're thinking about obturating. If you've got 90 minutes for your root canal, then irrigate for 90 minutes. If you've got 2 hours for your root canal, then try and get that irrigation going right the way through that procedure. Obviously, we're using safe-ended needles in our little endodontic syringes. The top tips though, number one, as I say, turnover is key. Irrigate right the way through the procedure. And if you're using the little 3cc syringes and the blunt-ended needles, a second tip is only to fill those syringes 2/3 full. That way you have the ability to aspirate back. If the needle is full, or the syringe is full rather, and the plunger is right at the end of the syringe and you try and pull back, you'll get irrigant everywhere. So only fill the syringes 2/3 full. That means you can control the drips. It also means that when you're down inside the root canal, as you can see in this video, you're able to aspirate back and effectively dry the canal. Rather than using 99 paper points, you'll end up using 2 or 3. A common question is whether we should do our endo in one visit or multiple visits. So tip 7 is around single visit endo. Lots of research has shown that when you compare the outcomes of single visit endo versus multiple visit endo, there's no difference in success rates, in post-op pain, or in the quality of obturation. There are occasions when you might want to adopt a two-stage approach. That patient we saw earlier on, where we weren't quite sure what the cause of her symptoms were, and we wanted to demonstrate to the patient that redoing the root canal was the right course of action. In those cases, it's useful to dress the tooth with calcium hydroxide and review the patient maybe 3-4 weeks later, when hopefully the symptoms have resolved. Other occasions include when it's impossible to dry the exudate from a canal, either pus or blood. In those cases, we would dress them and come back a couple of days later. Given on the basis that there is no evidence for any difference in the outcomes between single or multi-visit endo, but also considering that as lovely as you are, your patients don't really want to come and see you twice, And also it's much more cost effective for the practice. If you can complete a root canal in one visit, you should try to. Tip 8 is around obturation. Now, as endodontists, we obturate root canals in order to create a nice coronal to apical barrier, as many layers as we can to prevent reinfection of that root canal. So it starts with your crown and your core material, and then the layer of filling you've put over your GP, and then the GP provides that additional layer of seal right down to the apex. Inevitably, when we perform a root canal, there are going to be bacteria left inside that root canal space. So the other reason for obturating is to entomb those bacteria in that root canal space and deny them any space or nutrients in which to grow and recontaminate the root canal. We spend a lot of time looking at our x-rays and judging our outcomes from the appearance of that nice white line right down to the apex. However, the factors that predict a good endodontic outcome were shown in a study by the team from the Eastman in 2011, and the reference for that study will be at the end of the video. They showed that the prognostic factors in those that determine the potential outcome of a root canal include the size of the apical area before you start, the absence of a sinus, achieving patency, as we talked about earlier. If you can achieve patency, particularly with retreatments, that's a great sign that you're going to have a good outcome. Cleaning as close to the apical terminus as possible, effective irrigation, no perforations, keeping the root canal filling within the root canal space, so no overfills, and the provision of a good coronal seal. Those are all things that dictate success or failure within root canals. In that study, and in other studies like it, there is no mention of the obturation system that you use having any effect on the outcomes of treatment. Here we can see an image of a very large apical lesion that has resolved nicely, but the reason that has resolved is not down to the obturation that I've used. So, on the basis that there are dozens of techniques out there, lots of materials for obturating root canals, and there is no evidence that one system is any better than the other, aside from maintaining apical control, really it's down to choosing a nice, simple system for obturating root canals. The new tapered GP points that will inevitably come with your rotary file are matched to the shape of that final file, so it's almost impossible to use cold lateral condensation with systems like that. So the majority of people who aren't using a heated obturation system are actually obturating their root canals using a traditional sealer and a matched GP cone, which is a single cone technique. And we've all retreated teeth sometime down the line where we've seen those traditional sealers have broken down and you're left with a GP point sat in a black gooey mush. Advances in sealer technology mean that we now have bioceramic sealers, such as SureSeal here. Bioceramic sealers are antibacterial, they show zero shrinkage, they're biocompatible, they're incredibly easy to use, they're cost effective, and they will work with whichever file system you use. And the beauty of them is you need absolutely no special equipment whatsoever. All you need is your matched GP point and your SureSeal. So there are two ways of using your bioceramic sealers. You can either inject them into the coronal part of the canal and then coat the GP point and pass that down to length, or you can dip the GP cone in some of the sealer, and I tend to use the syringe tip as a little well. So use that syringe tip as a well, coat the tip of the GP point, pass that down to length, taking your sealer down to length, and then do a second dip to coat that GP point and fill up the root canal. And you can see from the video you get very quick, simple 3D obturation using a matched GP point and the bioceramic sealer. And then it's simply a matter of cutting off the GP point, ideally down into the canal a little way. I tend to use an ultrasonic tip. You can use heat, but I find a dry ultrasonic tip is much more effective. So tip number 8 is success in endodontics is multifactorial. The obturation system you use will have minimal impact on the outcome as long as you get everything else right. So as long as you can clean the canals effectively, you don't overfill, you get good apical control, and you get a good coronal seal. As Leonardo da Vinci once said, simplicity is the ultimate sophistication. So use a nice simple technique that fits in with your rotary system, and these bioceramic sealers will, for most people, give very effective obturation. Tip number 9 is around the coronal seal. The concept of the coronal seal is not new. The importance of it was highlighted by a seminal study by Ray and Trope in 1995. They looked at over 1,000 root canals and looked at the influence of the quality of the root canal and the quality of the restoration on the presence or absence of apical inflammation in those teeth. They split teeth up into those that had a good endo, those that had a poor endo, those that had a good restoration, and those that had a poor restoration. And they compared those 4 factors with the outcome in terms of absence or presence of apical inflammation. Now, not surprisingly, those teeth that had a good endo and a good restoration had a very high success rate, up at 91%. Also, not surprisingly, those teeth that had a poor endo or a poor restoration were the ones that failed. They only had a success rate of around about 18%. What was quite surprising though was when they looked at those teeth that had a poor endo but a good restoration, and also those teeth that had a good endo and a poor restoration. You would imagine that the outcomes of the endodontic treatment would be influenced more by the endo than it is the coronal restoration. But actually, when we look at those teeth with a poor endo but a great, nicely sealed coronal restoration, they had a 68% success rate. Conversely, those teeth where the root canal was great but the coronal seal was poor, that success rate dropped significantly down to 44%. So there was a significant difference between those two groups of teeth. And it's clear that once you've done the root canal, the quality of the coronal restoration is key to long-term success. So tip number 9 is that once you've completed the root canal treatment, the restoration is the most vital element in that long-term success. And there are 2 elements to that coronal seal. Number 1, it's the first layer of ideally something like glass armor over your GP. If you can cut that GP down below bone level and then place a layer of glass armor down over into the root canal, over the GP and into that pulp chamber, that provides a great first layer. Then your core material, and then after that it's around cuspal protection. So in the past we would always have said that everything distal to a canine ought to be crowned. These days, we talk about cuspal protection. So yes, in most cases that will be a crown, but it could be an onlay, an overlay. It could be, in the right circumstances, it could be a much more conservative restoration. But generally, a nice layer of glass armor over your GP, cut down below bone level ideally, and then a good solid tooth restoration that provides the tooth with coronal protection and a nice coronal seal. The other thing to bear in mind is the timing of that restoration. Ideally, we want to restore those teeth as soon as we sensibly can. These days, with single visit endo and the ability to use something like CEREC for a single visit crown, we can do it all in one visit. From a practical point of view, patient's going to be in the chair for a long time. Sometimes it's more sensible to do the root canal and review them 2 or 3 weeks later to make sure that they're now comfortable and then move on to the restoration. But I certainly wouldn't wait 6 months to find out if a tooth is settled before restoring it. If you wait 6 months, the chances are they'll fracture it at 5 months and 30 days. Tip 10 is around the decision whether you should treat a tooth yourself or consider referring it on for specialist care. There's a great document called the Index of Treatment Need, published by the NHS and the Royal College of Surgeons. This covers all of restorative dentistry, prosthodontics, periodontics, and also endodontics. And it gives a great guide as to what would be considered appropriate for a general practitioner, what might be considered more appropriate for a dentist with a special interest, or what ought to be referred on to a specialist. And it splits it into Tier 1, Tier 2, and Tier 3. Tier 1 is something that every general practitioner should be able to manage. Tier 2, for instance, would be where the canal is curved, somewhere between 15 and 40 degrees, or where the canal appears sclerosed coronally, but actually is visible along its full length, or where you've got an immature apex. And that's the sort of case that you could justifiably say to the patient, you know what, this is beyond my skills and training. I prefer to refer you on to somebody who has a special interest or a specialist in endodontics. Tier 3, for instance, would be where you've got more canal curvature, so over 40 degrees, or where the canal appears sclerosed along its entire length, or where there's a perforation to manage, or when you've got apical surgery. And this document runs you through all of those scenarios and gives you good guidance on whether you should be considering taking that tooth on yourself or passing it on. But But bear in mind that according to a report from the Dental Defence Union, 23% of complaints are endo related. And yes, endo can be made easier and more enjoyable, and hopefully this sequence of videos will help you with that. And there are great products and new techniques out there, but it's important not to be badgered by patients into taking on teeth that are beyond your comfort zone. Assess teeth carefully, and if in doubt, refer.